rhythm, there is a pause, another junctional escape, again a pause, a P wave which is not conducting, but subsequently you see at the end of the slide there is a sinus rhythm. It will definitely come back. Okay? Or secondly, you can have a very smooth transition like this of an SVT to a sinus rhythm. So these both are effects which you will get with adenosine, and be very, very carefree about using that drug. It is going to be the least, I should say, emergency creating drug for you in the clinic. Okay, another ECG please. So please tell me to stop whenever my time is out.
5 minutes, 5 or 7
5 minutes more? Okay, sir. Thank you. Another 5 minutes, so I will eat your head for another 5 minutes and show you at least 5 more ECGs. Is it a normal sinus rhythm? Tachycardia, exactly. Very nice. What is the exact rate on the tachycardia? Do you see about 10 small squares? It is a constant rate of 150. When you see a constant rate of 150, what do? VT. Is it a narrow QRS or a wide QRS? So do you have a VT on a narrow QRS? Highly unlikely. Whenever you see a narrow QRS, the first thing you look at is a supraventricular tachycardia or a, but if you see a rate of 150, what do you look for? Sorry? Paroxysmal atrial tachycardia, that is now we commonly call it as paroxysmal supraventricular tachycardia. I've already shown you 2 ECGs, so just a hint, maybe this third ECG is not PSVT. Who said atrial flutter? Excellent, excellent diagnosis. Whenever you see a rate of 150 on a monitor, a constant rate of 150, always look for a hidden P wave. Because 150 constant rate has to be, if otherwise proven, has to be atrial flutter, and you will always find 2 flutter waves and 1 QRS. It is always at a 2:1 conduction because atrial rate is 300 and ventricular rate is 150. This is how atrial flutter of a typical variety is maintained in most of these patients. So if you are in doubt, easiest thing to do is do the procedure I've just described, do a carotid sinus massage, and you will be able to unmask the flutter waves and you will be more sure of your diagnosis. Right? Let's skip this. This is a patient who came to me with the symptoms of recurrent syncopes, and his heart function was normal. He had a narrow QRS, normal sinus rhythm on the ECG. As soon as I took a detailed history, I just put him on a halter. And luckily I got an answer on the halter. What does this halter show? This is a halter tracing, please. Any clues, any cues? Is it a normal halter? Should I send the patient home and tell him to have a good life? Go to Hawaii for a vacation? It's a tachybrady syndrome. Why do you say that, please? So why do you call it a tachybrady syndrome? If you've so nicely diagnosed this as an AV block, it's a sinus tachycardia what the patient is having. Sinus rate, sinus tachycardia. And all of a sudden in the last end of the strip you see, there are P waves and there is just one wide QRS which is an escape rhythm. So the patient was going into intermittent complete heart block without any documentation on an ECG, which is a 12-lead ECG which we took during the daytime, and this is the reason for his symptoms of syncope. I gave him a pacemaker, he's doing fine, having vacation in Hawaii, right? So an investigation like halter is very, very important, though it gives us a 24 hours diagnosis, and we have halters up to 7 days recording now. In case we are able to pick them up, this can give permanent answers to the patient. So please don't shy away from these investigations like halter, which are non-invasive investigations, and they give us answer over and above our clinical discretion. Okay, my last ECG, please. This is my very favorite ECG. Okay, you want a hint? How many of you have been using a very, very old drug with the name of digoxin? How many of you use that? Okay, only 3 people, 4, 5 people. Only 5 people. 6, 7, okay, 8. 8 people, okay. Anyway, this ECG can come up in case patients are on digoxin and they develop a digoxin toxicity. There is a bradycardia, no doubt about it. We all agree there is a bradycardia, right? Is there anything more to it? Hypokalemia with digoxin does cause digoxin toxicity, it precipitates digoxin toxicity. You improve the potassium level of the patient, withdraw the drug for a couple of days, patient's rhythm does recover. But at times, you may need to give these patients pacemaker. Now why I'm saying this is, if you look at very carefully, you think this is a sinus bradycardia? Yes or no? Dr. Agarwal is staring at me. Please hurry up. This is my last slide. He says my time is out. Is this a sinus bradycardia? No. Why do you say that? No P wave. Excellent diagnosis. Who said this? Oh, excellent. I have to get friends with you. You're doing a real good job. There is no P wave. Everybody agrees? Okay. Can you see a bizarre activity here? The baseline is totally bizarre. Atrial fibrillation. Who said that? Who said atrial fibrillation? Very nice. There is an atrial fibrillation. He is right. The atria is in fibrillation. But don't we know that atrial fibrillation has to be with the irregular heart rate? Isn't that the definition of atrial fibrillation? Yes or no? Yes. But here we have a constant rate. And we have bradycardia. We decided we have bradycardia, right? So what is happening here? Yes, please. Absolutely right. You see there is a right bundle branch block. V1 is right bundle branch pattern. You see there is V1, the lead 1 is negative. That means there is a left posterior hemiblock. So patient has an underlying conduction system disease. And whenever you see atrial fibrillation, whenever the atria is fibrillating and the ventricle is at a fixed rate, there is no other diagnosis but an underlying complete heart block. You withdraw the drugs, but in most probability you have to give these patients a pacemaker and the patient improves magnificently. Thank you very much for being an excellent audience.
Dr. Natrajan, to please.
Vanita, that was an excellent talk. Very informative and very simple. Now the climax was the last slide, because we must tell the audience that the commonest arrhythmia is atrial fibrillation. 1% of the adult population has atrial fibrillation, so I would call upon you for the next 15 seconds to tell the audience in a simple way and in a general way what is the latest concept in the management of atrial fibrillation.
This is too short a time to discuss, no?
No, just tell them generally.
Okay. Atrial fibrillation is a very, very common arrhythmia in our scenario, but most of the atrial fibrillation that we see is associated with rheumatic heart disease. Rheumatic heart disease, we go by, in case the atria size is within about 4 centimeters, we go ahead, load the patient on amiodarone and try to cardiovert and get the patient back to sinus rhythm. In case it is more than 4 centimeter, it is unlikely that patient will stay in sinus rhythm. So we just concentrate on the rate control so the patient does not feel palpitations and is happy. In case that there is a normal, there is no structural heart disease, that means patient either has a hypertensive heart disease or a diabetic or a age-related atrial fibrillation, then patient who is symptomatic, despite 2 drug failure, 2 antiarrhythmic drug failure,